Hi, we're going to talk about Chapter 4, it's Special Issues in Women's Health and Reproduction. It's a really long chapter, so if you need to take a break a couple times, that'd be just fine. Okay, so let's go ahead and get started. Talking about breast screening for breast cancer, first of all. So everybody needs to be doing self-breast exams at least monthly, and they need to have a professional breast exam done at least yearly on all women of all ages. So women between 40 and 44 have an option to start mammograms. According to most insurance policies and the American Cancer Society, women have the option to start at 40 to 44, but all women should start mammography by age 45. Once they reach 55 and there hasn't been any issues, they can go down to every 2 years. If you are at high risk for breast cancer, if you've had a sister, mother, grandmother, something like that that's had breast cancer, they will start doing screening way earlier, and that will be up to your primary care provider or your obstetrician what they want to do, or your gynecologist. So when you go for your mammogram, just make sure that you teach your patients not to use any deodorants, powders, lotions, or anything before the mammogram, because it can change those results a little bit. Okay, so self-breast exams, we kind of talked about that already. Just make sure that we're teaching people to do those pretty much monthly. We want to do them about a week after your period is over, and that kind of helps get things going. You just need to know what is normal and what is abnormal. So when something abnormal comes in, you're able to identify that and get to the doctor quick enough to hopefully get it treated. Breast cancer is extremely treatable if it's caught early. So that's why we want everybody to start doing their self-breast exams. Pelvic and Pap exams. We used to do Pap exams very, very early if you were sexually active. Now they're waiting till 21, regardless if they're sexually active or not, and they're doing them every 3 years. The HPV vaccine has been very instrumental in decreasing cervical cancer. And so if they've had the HPV vaccine, we're seeing very, very minimal cervical cancers right now. So it's very important that we also teach about HPV vaccines starting in young girls. We usually start those about 6th grade, and it's a series of 3. Your Pap tests are done every 3 years. The doctor will also screen for other things when you come in for those exams. Okay, so vulvar self-exam, that's just making sure you're aware of your own anatomy. Make sure you look for any lesions, redness, growths, moles, skin tags, anything that looks kind of abnormal. You can get vulvar cancer, so it's important to let people know that they need to be looking out for that also. Okay, so now we're just going to talk about common disorders of the women's reproductive tract. So, common things that you're going to experience is something called amenorrhea. Now, amenorrhea, anything that starts with an A or an N, just means without. So these are women or girls that have not started menstruation. There's 2 different kinds. We have primary and we have secondary. Primary is where they've never had a period yet, and usually we start getting some concerns about age 15. So if they have not had their first menarche by age 15, then we want to investigate and kind of find out what's going on there. Secondary amenorrhea is where they've had an absence of 3 menstrual cycles or 6 months, or 6 months in women who have previously menstruated. So if they're missing, like if they have an absence of 3 menstrual cycles. So the most common cause of amenorrhea is pregnancy. So that's the first thing that the doctor would want to rule out if somebody hasn't had a menstrual cycle in a few months. He would rule out pregnancy. Sometimes it can be a hormonal issue. Sometimes PCOS can cause that. That's polycystic ovarian disorder, so that can cause that. Sometimes there's structural abnormalities. There are times where, an infant can be born without a uterus. They can be born without ovaries. Maybe their ovaries aren't active. There's a lot of different causes, so they would want to investigate and find out why. Atypical uterine bleeding. Atypical just means A without, so it's not a typical bleeding. So there's 2 kinds of types on this, and I want you to kind of know the difference. One is menorrhagia, and one is metrorrhagia. So menorrhagia is just heavy or prolonged bleeding. So this is somebody that they might bleed for 15 out of 28 days. That's menorrhagia. Metrorrhagia means they got normal menstrual bleeding, but it's at very irregular intervals between their menstrual periods. So menorrhagia is very heavy, prolonged bleeding. Metrorrhagia is normal menstrual bleeding, so they're not bleeding heavy or prolonged, but it's at real irregular intervals, so they really don't know when they're having periods and when they're not. Breakthrough bleeding, sometimes we'll see people break through bleeding with metrorrhagia if they're on hormonal contraceptives, because sometimes when you get on birth control, they will have some irregular bleeding episodes for whatever reason with the hormones, and then usually that will stabilize out. Dysmenorrhea. So dys means painful. So this is going to be painful or difficult menses. So there's primary and secondary in this one also. Primary is not really associated with any disease process. It's usually young girls that have started their periods. Sometimes the body produces prostaglandins that causes that uterine contraction, and your body hasn't done it much before, so it may produce more prostaglandins, causing more pain and stuff during that menses. Secondary, it's usually going to be due to some type of pelvic condition. Endometriosis, uterine fibroids, something like that. That's going to be causing the pain. So what are they going to come in with? So a lot of them are going to come in with, usually this is going to occur about 6 months to 2 years after they have menarche or after that first period. They'll have intermittent cramping, maybe they'll have constant pain, nausea, diarrhea, fatigue, headache, a lot of signs of kind of like PMS. How do we treat it? Well, there's a couple ways we can treat it. One, you can give them Tylenol, that will help. And NSAIDs. Remember I said that when you get that contractions of the uterus, it's usually due to an overload of prostaglandins. We have something that we can give them called a prostaglandin inhibitor. And basically that's like ibuprofen. That's a non-steroidal anti-inflammatory drug. And those are prostaglandin inhibitors. So if that young girl is producing lots of prostaglandin, we can inhibit that prostaglandin from being produced, which will then help with those contractions. Oral contraceptives is also another thing that can help with dysmenorrhea and help with some of that pain. Premenstrual syndrome or PMS, it's a physiological and emotional symptoms that occur during that second half of your menstrual cycle. So it kind of comes along with physical symptoms and behavioral symptoms. Physical symptoms, you'll get the breast tenderness, abdominal bloating, headache, swelling of the extremities. Behavior, this is where they're going to cry all the time. They might be very irritable. They might be angry. They might have confusion, depression, a lot of roller coasters. I say it's kind of like a roller coaster ride going around there because it's kind of up, down, happy 1 minute, sad the next. The cause of PMS is really unknown. So there is something that's a little bit more severe, and it is in the DSM now with our mental health categories. It's called premenstrual dysphoric disorder, or PMDD. That's a little bit more severe, and that would be diagnosed by a provider. But treatment for all of this is just specific to whatever signs and symptoms that you have. So we might give them some vitamin supplementation. Sometimes that can help with PMS. Diuretics to help with some of the bloating and the fluid retention. The NSAIDs, or those prostaglandin inhibitors, will help with that. Tylenol, anti-anxiety, antidepressants. Sometimes they will do that. I know, I'm not really sure what they're treating it with currently, but I know they used to give Prozac the 2 weeks before you would start your period. And they felt like that took some of the edge off of the PMS. Usually PMS will go away once you hit menopause or you become pregnant. So there's a couple things to look forward to. So relief measures, again, diet, exercise, stress management, sleep, rest, making sure you're taking care of yourself. Endometriosis is a little bit different. Endometriosis is a very painful condition that women can get because endometrial tissue grows outside the uterus. So inside the uterus, we have endometrial tissue. Well, that endometrial tissue can get in the fallopian tubes. It can get out on the outside of the uterus. It can get on actually the colon. It can get on the mesenteric areas in there. And it does cyclic pain just like it does monthly. So that is another thing, endometriosis. And the more it flares up, the more scarring that occurs. So somebody who's had endometriosis really bad, they might have a lot of scarring in their fallopian tubes, and they might have trouble getting pregnant after that. So things that they will present with, they will have menorrhea, they will have dysmenorrhea, and they will have dyspareunia. Dyspareunia is as painful sexual intercourse. So just kind of be familiar with some of those terms. Treatment depends on how severe it is and what is the extent of the disease, the desire for fertility, and what kind of treatments are they willing to do, and what is the goal at the end. For mild pain, NSAIDs, again, that's those prostaglandin inhibitors, or your oral contraceptives. Now, oral contraceptives will prevent that shedding of the lining, so a lot of times your women that have endometriosis, it really improves when they're on birth control because it stops that shedding of that lining. So those are kind of things that we might do. There's also another severe thing that we can do. We can actually put them into an induced menopause, and that will stop the growth of that abnormal tissue and relieve some of those symptoms. But that would be up to your provider on what they would want to do with that. Okay, now we're going to talk about infectious things. Things that we can get an infection from those. So toxic shock syndrome. This is caused by the exotoxins, or the toxins that are released from the Staphylococcus aureus. Usually these are caused by tampons or something that's left in the body cavity that grows bacteria. So usually this is going to come on very suddenly. They're going to have a very, very high temperature, nausea, vomiting, abdominal pain, rapid drop in blood pressure, watery diarrhea, and then headache, kind of what you would feel like if you had the flu. But then they're going to develop that sunburn-like rash within 24 hours. So sometimes that's when women come in, or young women come in, and they come in, it looks like, flu-like symptoms. That's where we got to have a lot of differential diagnosis and make sure that we're getting to the bottom of what is actually causing their problems when they come in. It's a medical emergency. A lot of times this is a septic problem. So it's going to be an ICU admission, fluids, antibiotics, things to make sure that we're treating it appropriately. PID, pelvic inflammatory disease, just means that we have an inflammation in any part or any portion of the reproductive tract. Most common, it's related to an STI, or a sexually transmitted infection that you have that, if it goes untreated, can cause further damage and stuff later on. So a lot of times they will get these pelvic inflammatory disease, maybe from a gonorrhea, chlamydia, and they didn't even know they had it. But if this goes untreated, it does cause scarring of the fallopian tubes, where they can get ectopic pregnancies, chronic pelvic pain, peritonitis, sepsis, all the things that can happen. Treatment, well, it can be very challenging because we got to figure out what is causing it first. So is it one of the STIs? Is it a virus? What is it? So a lot of times they will go ahead and try a wide spectrum antibiotic just to see if that works. We do know what works for chlamydia, and we do know what works for gonorrhea. In your ATI book, I would go ahead and just kind of look up what is the treatment for your chlamydia and your gonorrhea. It's specific types of antibiotics. Once it's identified, all partners need to be treated. Even if they don't have symptoms, they need to be treated because they can be asymptomatic but still carry the disease. This is disorders of the uterus and ovaries. So cervical polyps. So these are benign. Usually they're benign little tumors. They can be associated with infection or chronic inflammation. So it's something that the doctor wants to look at if he sees something on the cervix that looks just kind of unusual. So what are they going to present with? They're going to come in with postcoital bleeding. That just means that after sexual intercourse, they will have bleeding. They will have metrorrhagia, which is going to be, have that irregular bleeding. They might have menorrhagia, where they have the prolonged, heavy bleeding. They might have leukorrhea, where they're going to have a lot of white discharge. Treatment, they got to remove them. So they're going to have to remove those polyps, and usually they will go ahead and give you prophylactic antibiotics just to make sure that there's no type of infection trying to form. Uterine fibroids. Most of the time these are benign also, but a lot of them are estrogen responsive tumors. And so if they're estrogen responsive, which means the estrogen kind of feeds them, it's kind of like their food. So when estrogen goes away, the tumors kind of go away. So once you go into menopause, a lot of those tumors will regress because they're not being estrogen fed. It's more common in Black women. Many don't have any symptoms, but they can get really big. And once they get really big, they can start causing pelvic pressure. They can have pain, menstrual irregularities, and it can cause problems during pregnancy because sometimes these, if it's estrogen fed, sometimes the uterine fibroids will compete with the baby to see which one can get the biggest, and sometimes it can push the baby out of the way. So treatment is just going to vary. Surgical removal, myomectomy, uterine artery embolization, which what they're going to do there is, if we know what blood supply that fibroid is getting, if we cauterize that blood supply or we stop the blood supply to that fibroid, then the fibroid will just kind of shrivel up and die. And then there's pharmacological things that we can do. So ovarian cysts, these are just fluid-filled sacs on the ovaries. A lot of times this is happening when the follicular state, when the body is starting to release the follicle, it comes out and it forms like a cyst type thing. Many times these will rupture and they will go away, but sometimes they don't. Sometimes they can get very large. Sometimes they can be very, very painful. You may or may not have symptoms. Some people may have them and they may not have symptoms, but they can lead to some complications. PCOS or polycystic ovarian syndrome, sometimes that is diagnostic if they have lots of ovarian cysts. Treatment is just going to kind of depend on what the cause is and how it's going and where the female is in her fertility cycles and where she wants to be to have babies. Oral contraceptive is one of the biggest treatments because it prevents those follicles from forming, because we don't ovulate. So it prevents those follicles from forming. Therefore, if the follicles don't form, we don't get those cystic-like things. The cysts. Pelvic floor disorders. So we're going to look at pelvic support disorders. So this is just where things aren't holding tight like they should. So it's just weakening of those structures that support all those pelvic organs that support all of that. So we can have something called a cystocele, rectoceles, or we can have a prolapse of the uterus. So sometimes when things aren't tight in there, the uterus can actually prolapse out. Rectoceles is where the vagina can actually push into the rectal area. Cystoceles is where the vagina can push into the bladder. So major risk factors for this: pregnancy, because everything gets stretched out, everything gets moved around, the baby comes through that birth canal, the pelvic floor never goes back to the same tone that it had before. So that is one of the things that can happen, and just poor muscle tone. So other things that can cause it is, somebody who has obesity, it's increased pressure down there causing that pelvic floor to lower, chronic coughing, chronic constipation, and a hysterectomy. If we remove everything out of there, things are going to shift and go into different places. Manifestations, they might feel a heaviness or pressure in that vaginal area. They might have painful sexual intercourse, which is just dyspareunia. They may be asymptomatic. They might have urinary incontinence, and that's what takes them to the doctor. Constipation, all of those kinds of things. So treatment, well, the treatment's going to vary depending on how severe it is and what the woman really wants. So a couple things that we can do is teach them like Kegel exercises, squeeze and release, squeeze, release, increase that tone in that area. Weight loss, if it's obesity, avoid heavy lifting, quit smoking because we know that does that. Proper nutrition, make sure you're getting all your protein to build all your fluids back. Proper fluid intake, make sure you're cleaning well front to back. So all those are going to be important things to make sure that we teach our females about. So when we and I'm not going to really get into this, but this is just the major milestones as far as like the reproductive issues and how we go through. So we start out prenatally all the way to our late or reproductive capability. So just kind of be aware of what stages that people are in. So family planning. So a lot of people want to plan their families. And so when you plan your families, it kind of gives you a little bit more control over when we want them, how many we want, kind of determines when they're going to be born, when I'm going to have my cycle, when my reproduction is going to stop. So we can plan that out based on all the information that we have in our hormone levels and things like that. So the next thing we'll talk about is preventing pregnancy. So there's lots of different methods that we can talk about with that too. So preconception care. We recommend that every female that is thinking of getting pregnant go to their healthcare provider at least 3 months before they get pregnant. because that way the doctor can talk to them about eating healthy, staying active, making sure you're exercising. Go ahead and start that daily additional supplement of that folic acid to help with those neural tube defects. Help protect against STI or any other infections that they might get. Avoiding harmful chemicals, any metals or toxic substances. Maybe you work around something that is known to be, tetrogenic. So maybe we can stop those kinds of things. Maybe you're taking a medication that has tetrogenic effects. Maybe you have high blood pressure and you take an ACE or an ARB. You can't take those if you're pregnant. So they're going to have to switch you, and we want to make sure that that's right before we actually, get into some problems with blood pressure problem. Make sure all your vaccines are up to date because you can't get live viruses when you're pregnant. So we want to make sure all that's up to date. Reduce your stress level. That will help with sometimes the conception process, and stop smoking. So all that is, the smoking constricts all those vessels and causes, conception to be a little bit more difficult. So they will want you to stop using any street dogs, which I think that you wouldn't be doing. Stop alcohol, all that kind of stuff. Intimate partner violence. A lot of times people think if they get pregnant, that will get better. Actually, that escalates it and makes things worse. Manage any pre-existing health conditions. So if this mom comes in again, she's on an ACE inhibitor, we can talk to her about, how do we keep this under control, the 9 months that you're going to be pregnant. Maybe she has type 1 diabetes and she takes insulin every day. We want to make sure we're getting that glycemic index under control. Learn about their family history. So what's going on with their family history? Did they have any problem? Did anyone in the family have any problems getting pregnant? Did anybody have a stillbirth? Did anybody have genetic abnormalities? Did anybody have, all these things need to be checked on. And make sure you're getting your regular checkups to make sure the doctors are keeping track of all of your vaccinations, all of your screenings, all of the things that you need to be doing. So now let's start with preventing pregnancy. So natural methods is the first one we're going to talk about. So we're going to talk about abstinence, coitus interruptus, lactational amenorrhea, and fertility awareness methods. And those are just like the calendar method, basal body temperature, cervical mucus, ovulation predictor tests, all those kinds of things is what the natural method is. So the calendar method, these are your natural methods. So the calendar method just kind of determines what your fertile days are going to be by tracking your menstrual cycle. So the estimate is usually about 14 days before the next menstrual cycle. So we start counting on the very first day if you have a 28-day cycle. So 14 days is going to be probably your most fertile time. And then the other 14 days, and then you're going to have your menstrual cycle in there. So you're going to have your period's going to be for those 7 days. Then you're going to be, the follicle's going to be making for those 7 days. And then you're going to ovulate. And then if it's not fertilized, it's going to start the cycle all over again. You're going to go 14 days. So ovulation is important to kind of understand that. So sometimes people will use these cycle beads, and it's kind of like the calendar method. It tells you what your fertility days will be. Basal body temperature, when you ovulate, your basal body temperature will go up a little bit. So if you take it every morning, you will notice a slight rise when you ovulate. Now, cervical mucus ovulation detector, this is called Billings method. This is where you look at the cervical mucus every day and you kind of look at it. And when ovulation's getting closer, the mucus is going to become thin and more flexible because it's real thick in other times. That way, because the sperm can't really get through it very well. But when it's thin and very flexible, the sperm can kind of just swim on through that and get to where they need to be. Now, so that's why they tell you to take your mucus and kind of put it between your fingers and see how much thickness or what kind of stickiness that there is. This is called spin barquette, and that's when the mucus looks real slippery and kind of slimy. And that's just a word that we use. I don't really know why that word is there, but that's the word. 2-day method, that's just checking those vaginal secretions daily. After 2 days, with the absence of secretions, that fertile period is passed. That's just a couple methods. Now we're going to move to barrier methods. So these are other methods that we can do. Spermicidal agents, these are just chemical barriers that stop the sperm from being able to penetrate up into the cervix. Condoms for men, Biggest thing about condoms is they need to make sure that they know how to put them on, make sure that the expiration dates are correct, and it does help with STIs, so it does prevent STIs. Condoms for women, it's kind of like a vaginal sheath. It just goes inside the vaginal opening into the cervix. Just make sure you know how to use it. It will help with some STIs if everything stays in place. Diaphragm and a cervical cap. These are very good at preventing pregnancy. If you use a diaphragm or cervical cap, you usually have to put on top, you'll have to put a spermicide, and they have to be replaced every 2 years. Or if you lose a lot of weight, if you lose 20% of your body weight, you have to have your diaphragm refitted, and it has to be used with that spermicide. The biggest thing about your diaphragm, it has to stay in place for 6 hours after intercourse. That way everything can get killed and we don't accidentally send something up inside there. So that's the big things about your barrier methods. Now, hormonal methods, this is going to be your birth control method. So this is going to be what birth control is going to do. We have oral contraceptive pills. This is what most people use. It prevents ovulation. It hormonally suppresses ovulation, so you don't ovulate anymore. Your secretions are a little more thick. It prevents any kind of implantation into the uterine lining. Then we have something called a progesterone-only pill. This is a pill that can be used if a mom is breastfeeding. So if she's breastfeeding and doesn't want to get pregnant, she can take this progesterone-only pill. Hormonal injections, these are injections. It's medroprogesterone. These are IM or sub-Q, and they're every 11 to 12 weeks, and what they do is prevent ovulation. Biggest thing with these is weight gain. Hormonal implants, these are little rods of progesterone that is implanted on the upper arm. It also stops ovulation, but they're good for 3 years. They also have a weight loss indicator, a weight gain indicator on those. Transdermal patches, they have estrogen and progesterone. And this is where the patches absorb through the skin and prevents ovulation with that. Vaginal ring is a silicone little ring. The ring goes in, stays in place for 3 weeks. You take it out, you put a new ring in after you've had your period for 7 days. And that's a hormone also. Now, biggest thing about oral contraceptives. There are big risk factors with oral contraceptives. If you have a risk of deep vein thrombosis or you have a risk of blood clots, you would not be a candidate for oral contraceptives. If you've had a stroke, not a candidate. Heart attack, uncontrolled hypertension, smoking, all of these things would be contraindications for putting someone on birth control. So if you had someone come in and they were 20 years old and their blood pressure was already high and they're a smoker, you're probably going to tell them that they don't really need birth control. Or if you have a mom that just delivered a baby and she has preeclampsia and her blood pressure is not going down and she's a smoker, we're probably going to tell her she doesn't really qualify for birth control methods. So if they don't qualify for birth control methods, they don't want to do the barrier and they don't want to do the natural methods, what other kinds of things are there? Well, there's something called an IUD. It's a non-hormonal kind of a copper device. There's different types of IUDs. So that's the biggest thing. No, there's different kinds of types. Most of them are non-hormonal. There's a couple that have a couple hormones in them, but they're local hormones. They release some type of chemical that damages the sperm. They keep the uterine lining irritable, so there won't be implantation. These are good for 3 to 5 years. They are a little bit painful to put in, but the biggest thing with these is with birth control, we want you to get off birth control 6 months before you get pregnant. With an IUD, all you have to do, go to the doctor, they pull it out, and fertility is restored. So you don't have that waiting period to get pregnant. So your fertility returns immediately once that IUD is out. You don't have to wait anymore. And then sterilization, if you choose not to have any more babies at all, then women can get what we call a tubal, where they just cut and ligate and tie off the tubes. Men can get a vasectomy, where they cut the vas deferens and they tie that off too. Now, the biggest thing for women, it's a instant sterilization. For men, they can still have live sperm in there up until about 20 ejaculations. So people have went home and think, well, I had my vasectomy, I'm good, and they end up with babies. So just make sure that you educate them on that. Emergency contraceptives, if someone has had, they don't want to have, they've had unprotected sex and they are not on any form of birth control and they know it was the right time of the month, they can go do this pill. It's called the morning after pill. And it has to be taken within 72 hours of the event for it to work. So we just need to make sure we let them know. Abortion. There's different types of abortions, but this would be an abortion that we choose. So we have spontaneous abortions. That's just the miscarriage. We've talked about those way back in prenatal. But there's other types of abortions that we can give. One is medical. So we can do it with medication. So misoprostol, remember that one? That's a uterine stimulant. Miprostone, methotrexate. What methotrexate does, it's kind of a cancer drug. And what methotrexate does, as soon as you take it, it stops cellular division. So, and what are babies doing? I mean, rapid cellular division. So it's going to stop all that rapid cellular division and it's going to kill the embryo. So that's how that works. Misoprostol just induces labor to make you have an abortion. And those are medical with medications. Surgical is aspiration, where they go in and they aspirate it. D&C is a dilation of the cervix and curage. D&E is a dilation and evacuation. So those are more of a surgical type of procedure. Okay, infertility. So what types of infertility things do we have? That is just the inability to conceive after routinely doing something for 1 year with no protection. So risk factors need to be identified, so they'll have to have meetings with both mom and dad. What things are maybe presenting them, what kind of things do they do that could make them have trouble being fertile? Is it occupation? Is it environmental? Is it emotional stress? Is it behavioral factors? Do they have stressful jobs? Are they working someplace that may be causing something to happen? If it's female, does she have PCOS? What is her age? Does she have any chronic conditions like diabetes, hypertension, muscular dystrophy, anything that might have that? Any hormonal imbalances, any tube transport problems, any implantation problems. Maybe there's scarring from PIDs or something like that. Now, specific to men, that's just specific to men, sperm viability. If they have bad sperm, they just don't swim well, they can't get to where they need to go. Maybe they don't have enough sperm. Maybe sperm deposition interference. Maybe the female's vaginal tract is very acidic and it's killing everything as it comes in. So there's lots of different things. So evaluation starts, we start with the least invasive first and then progress to more invasive and complex techniques if certain things don't work. So we have to do a very thorough history and physical and exam on both people. So they're going to do lots of testing, figure out what's going to go on. They're going to do like a sperm analysis and see, what kind of sperm that they have. So it kind of takes the spontaneity out of getting pregnant. But, if we don't know what's wrong, we can't fix what we don't know. So management, we got to figure out the underlying cause. How long have they had infertility? What's her age? Because if you got a mom that has never had any children and maybe she's 40 and wants to have a baby and maybe she said, we've tried for 3 months and we can't get pregnant, would you be willing to start infertility now? Well, if she's 40, they may because of her age. But if she was 30, they would say, let's try these things first because it may happen on its own. So we're going to start with the simplest, least invasive, move on to the most invasive. So there's things that we can do. There's medication we can give. There's hormone replacements that we can do. There's surgical procedures where we can actually go blow out the tubes. We can do IUIs, which is artificial insemination. There's other advanced reproductive techniques like in vitro, all of those kinds of things. And then there's something that they would talk to you about if none of that worked. Surrogacy, things like that, adoption, things that you would look outside of the box for. So psychological aspects of infertility is very, very difficult though. A lot of times if they find out something is wrong with them, there's a lot of guilt, shock, They get really sad. Depression's a big one, and it's very stressful in the marriage. It's very stressful on both people because many times they're trying to work. The spontaneity is taken out of the relationship, and it's like, okay, we have to do it right now because this is what we have to do. And it kind of just puts a damper on things. So a lot of communication is going to be very important between partners, between healthcare providers, between their nurse, all of that kind of stuff. And, talk to them about not being embarrassed because this is, part of what we have to do to make sure we keep things under control. Reinforce any types of coping mechanisms that they have, make sure that they're understanding everything, all that. Okay, menopause. Menopause is just when menses cease and women stop producing all that estrogen and progesterone. So it is a part of the life cycle. It's not a disease. It's something that's going to happen to every woman as they age, but it is associated with certain kind of symptoms that are not pleasant. Hot flashes, insomnia, weight gain, bloating, irritability, a lot of emotions, headaches, vaginal atrophy where the vaginal tissue becomes very dry, and so sexual intercourse is very difficult. So how do we fix all these? Well, there is hormone replacement therapy. What they usually do is give you the lowest dose to control the symptoms. They might not eliminate them. However, we do know that hormone replacement therapy also increases the risk of certain cancers. So some women choose not to do that, and they just kind of go through it the best they can. So there's other lifestyle modifications that we can help them with. Make sure that they wear cotton clothing, make it in layers. So when they have those hot flashes, they can take that off and come back in. Avoid caffeine because that can make them worse. Nutritional supplements or certain nutritional supplements that can help with some of that. Use water-soluble lubricants. There's non-prescription things that we can get. Have them start doing that can help. I think like black cohosh is something that can help with the hot flashes. Kegel exercises, because as that estrogen goes away, that pelvic floor support is going to get less. So they're going to have more bladder issues. More things aren't going to be tight in there anymore. So have them, increase all that. Make sure that they're doing those Kegel exercise. Practice very good hygiene. So of course you're going to do all these things. Make sure that you're doing your nursing process. And that's it.